today. I am very excited to talk about this paper from a number of different types of nuanced conversations that actually came out of the study. This is one out of many aspects of talking about this measure that we will dig in here to today. If you can go to the next slide. Just for a brief introduction as to what role I play in this. My name is Ray Martens. I am out in Calgary. I actually work for the University of Calgary through the Israeli Accelerator, through the Awerco Center, and I work with families, like as well as adults across the lifespan in the neurodevelopmental disability world. But what position that I bring to this particular study here today is as someone with lived experience, both as someone with a disability myself, but also as a bereaved parent who spent a lot of time in clinic settings with my son who passed away 5 years ago, who was autistic but also had cerebral palsy as well too. And it's been wonderful to be able to share not only my own lived experiences in this case, but with some of the families that I support, being able to kind of bring some of their stories to the conversation with the study as well. Kinga.
Sure. Ray forgot to say that she's a co-investigator. In addition to her work at U of C, she's also a co-investigator on a bunch of studies out of Canchild Center for Childhood Disability Research, which is in Ontario at McMaster University. Which is where I'm based. I'm a postdoctoral researcher at Canchild. I have to disclose I do not have a clinical background. My background is actually in sociocultural anthropology. But I have two kids. After having a son who got diagnosed with cerebral palsy, I sort of turned my life upside down and decided that my research needs to follow my life. So I came to Canchild, and now I am sort of embedded in health research. So that's my story. Go on,
One
Ray.
thing I want to ask as well too, while we are here, is if you have would like to share exactly what sort of position that, if you haven't already introduced yourself in the chat, what brings you here, both as a person with lived experience, as someone who supports people within healthcare systems, and if you're comfortable enough, though that you are under no obligation to disclose, if you walk both paths as well too, we are happy to hear from you as well. Next slide. And of course, our team is a wonderfully diverse amount of people from Canchild, upon whom I spend half of my time as well too, work-wise, working with the Family Engagement Research Training Program. We have Dr. Peter Rosenbaum, as well as who is known for the F words in childhood development. If you are unfamiliar with them, I'd be happy to put the link in the chat if there's something that you'd be interested in. We have a number of parents as well too, both representing from Ontario as well as from northern regions in Alberta. So it was a very unique experience for me personally to get a perspective more from the idea of creating measures and what as someone who took a lot of surveys in clinics and in some cases would see things like 4 lines trying to add my medical history to 4 lines, it often felt like I wasn't really emotionally connected to the work of evaluating how systems evaluated stuff. And so to learn from these people has been an absolute gift for me personally and professionally. Next slide. And just a little bit about Canchild here as well too. They have been around for, as you can see, 36 years. We recently celebrated last year that a significant anniversary. And one of the things that I have learned, and they were actually my first foray into partnered research as well too, is that they really do value the voices of lived experience within the work that they do, no matter the subject. There are kids, youth, and caregivers all have an opportunity in one way or another to contribute to the research, and that's something that I have come to value over the years as well too. Next slide. And of course, talking about family-centered service, one obviously needs to define what the scope is in terms of what we're talking about here today, and understanding that as a parent, when I come into the clinic, my story is unique compared to other families as well too. While we might have some commonalities, there are things that uniquely define us as a family unit as well too, and we need to treat them individually and not and think about all of the things that are composed of that family's life. That the family is a constant connection to that child's life as well too, be it communicators, be it support, be it a number of other different types of roles. That parents are experts in their child's abilities and needs as well too, understanding the nuances of what life looks like. Both at home and in clinic settings and in school settings and things like that. My son was the type of person who decided to put on an entirely different show in clinic settings, so I often had to show exactly or tell an appropriate story as to what things looked like compared to what they were seeing at a hospital appointment and things like that. Parents and healthcare providers work together to make decisions about services and supports, and understanding that unique relationship in terms of goals and communication is a very highly valued and very necessary conversation to have on a regular basis. And understanding as well, too, in this case from Dr. Rosenbaum's paper from 1998 here, that strengths and needs of all family members are considered in this conversation. Understanding that in order to pursue specific goals, that the mechanisms for success come from all parties that are involved in the system that is meant to support the child as well, too. Next slide. And so, what we co-created here was something called the measures of processes of care. This is a collective survey to talk about the process. So this was actually initially created. Now, remind me, Kinga, this was in the late 90s when this was created?
Yeah, so the original work on family-centered service started like in the 90s. So at that point, Canchild, I wasn't there, but Canchild developed the first like questionnaire, so the first measure of family-centered service, along with kind of a suite of like accompanying like knowledge translation materials. But then a few years ago, we realized, or everybody realized that, that was the 90s and healthcare has changed since the 90s and people's experiences have changed. So it's time to like go back to the drawing board and, learn what parents today want and expect from services. So we did that, and we developed a new measure, and we're developing new KT materials. Sorry, Ray. I'll give you back your
Not a
thunder.
worry. I appreciate that, King. Thank you for filling in the blanks for me. I thought that you might be able to provide a little bit more well-rounded description of that. And so in talking about this as well, too, just from an example standpoint, in the 90s we had like the dial-up internet. And so we were only beginning to start to access information as parents in terms of what was available to us and things that we could bring to appointments and how we could advocate and things like that. And obviously now within the system of Wi-Fi that we all currently coexist in, that's an entirely different system. We are more informed and understanding the values and needs of families in that particular case as well too becomes a different system of questions to ask in that case. And having been a part of some of the focus groups, there were things I can definitely say that I related to wholeheartedly. But then there are things as well too that I hadn't even thought about as well from my own experience. So to get the full scope of that was just a really interesting path to go on. Next slide. And so these are the key themes that emerged from these focus groups that we did. Understanding that these are things that families value within the care systems that they exist in, understanding that care needs to be coordinated, that some clinics talked to other clinics and made sure that it wasn't this thing where parents had to carry files with them and stuff like that we're all working together as a team. Supporting family well-being as well too, understanding that the whole unit is worth treating when it comes to talking about well-being from a wide variety of perspectives. Working together with families, understanding that they are partners and not just participants within the healthcare as well, and that they have thoughts, feelings, and ideas that can be helpful in this case. providing respectful care as well too. Um, a very important aspect of that. Communicating in a supportive and collaborative way. I think one thing that came up for me personally in terms of that from the focus groups was really the invitation to be curious. We might not necessarily be able to sometimes as parents elaborate on what is going on, concerns that we have, but offering that space to just kind of sort through thoughts, feelings, and just really helping people understand and validate that their perspective just needs a few added words and to support someone in figuring out exactly what that is kind and supportive and collaborative in that way. Making services available and accessible. Another aspect very important, especially with wait lists and things like that being a reality. And of course, as I mentioned before, providing supportive care. Um, Being able to see families shine in whatever way that is defined. And I've seen a number of different descriptions of what that could look like. Um, some of them, I think it was Hull and Bloorview Hospital talks about as defined by the child and the family, the healthcare that's um, healthcare that joins on that journey with you, essentially, in that way. So it's an interesting dynamic to see how it moves and how we begin to define that in the long run. Kinga, I believe you get the next slide.
Okay, so we wrote about different aspects of this work in in a few different articles, which we are happy to share if anybody is interested in reading them. Um, so one of those articles is the one that specifically got us invited here, and that's the one in the top left in the top left corner. So we thought it would be appropriate to say a few words about that article specifically, and but then I'm going to try to leave lots of room for discussion, so that people can pick up on any thread that they're interested in. So next slide, please. Okay, so maybe just to set the stage a little bit, here's some like big picture messages about family-centered service that we learned in the course of our work. Um, so family-centered service is, I mean, it's been around since the 90s, right? So by now it's a fairly established approach. In theory, every organization is family-centered, right? Or they have something about it on their walls or in their mandate or somewhere. In reality, people's experiences are very checkered, right? There are some organizations and some programs and some individuals that are doing a really great job, but it's not necessarily even across the board. And to this day, parents report a lot of negative experiences resulting from their interactions with the healthcare system, including things like stress and trauma and anxiety and exhaustion, and being treated disrespectfully, not being listened to, being forced to perform roles that they don't want to take on, and they don't that aren't really their place to take on. Um, the other kind of big picture theme that we learned is that many of the barriers to providing family-centered service are, really based in like organizational structural issues, right? So like lack of funding, long wait lists, not enough time for appointments, excessive bureaucracy and red tape, and of course, all of those are interrelated. And the last big point I want to make is that while we're doing this work specifically in the context of child health and child rehab, that doesn't mean that these things are unique to pediatrics, right? A lot of them are just about what good care looks like for anybody, anywhere, and adults who use healthcare services have families as well, right? So I imagine a lot of these themes are not, they're not unique to just the childhood disability world. And if anybody here is from outside of that world, I would love to hear, if and how these ideas resonate with you. Okay, so next slide, please. Okay, so specifically to the point of the experiences of sort of insiders with lived experience, when we were doing focus groups with parents, a few of the parents happened to mention that in addition to being parents, they were also pediatrics service providers, right? So either health or social service providers. And those parents had some unique insights that we thought were very valuable. So that was kind of like an aha moment for us, to go and to do some targeted focus groups and some targeted interviews, just with parents who also were service providers, or to put it differently, with service providers who happen to have their own children kind of in the system. So in the end, we ended up doing separate focus groups and interviews with 21 additional people, additional SPs, in addition to the ones who, just came to the mainstream focus groups. All of them had worked in healthcare context before becoming parents, and all but one worked in peds. And we had a good mix of, nurses, different therapists, so physios, OTs, SLPs, some child life specialists, behavioral consultants, social workers, dietitians, and all the participants had worked in clinical practice at some point. At the time that we interviewed them, two kind of moved on to like more management positions. One was in a teaching role. One left the field entirely, and I will come back to that point. And two had stepped out of work entirely, and were full-time caregivers, and I will come back to that as well. Okay, so I will now kind of highlight the key, like some of the key themes, or some of the like key things that jumped out at us from those interviews. If you could go to the next slide, please. Okay, so the first, and I'm sure this might be obvious to some people, but to set the stage, the lived experience of being a parent changes you, right? So the SP parents in our study talked about the different ways in which they had changed how they think about working with families and how they actually work with families. So they talked about having more empathy for parents. They mentioned having made some changes to the practice. So, for example, doing more advocacy work on behalf of parents, doing more to actually help parents navigate and coordinate care, and being mindful of the responsibilities parents have and not wanting to kind of overburden them with additional responsibilities. So I will. Sorry, I'm a qualitative researcher. I love quotes. So I will read you quotes because they give a feeling that it just doesn't, that you don't get if I'm just summarizing things. So here's one. The first one says, after going through this process with my son, my approach with the families is so different. I spent a lot more time helping them to advocate. Prior to this, I really do feel that the push from public health is to help parents advocate for themselves, to build their capacity. But the truth is, we only have so much capacity in these situations. I do think that it should be part of the professional's role to help families. It's simply not possible for that family to access supports for themselves sometimes. And the next one said, I didn't want to tell anyone to do any home programming because I went on strike against it myself. I understood how hard it was to work into your day and that it wasn't enjoyable, and I don't know what I was thinking before I had children. Okay, next slide, please. Okay, second big takeaway from those conversations is that and I'm sure people can imagine this, having, working in the system brings with it certain unique perks, but also some unique challenges, right? So the SPs we talked to were very cognizant of the fact that, it was a privilege to be able to ask their colleagues for, medical advice, or have a colleague, come do a house call on a sick child, or have their boss intervene to, help out with the wait list for services. And they also realized that, even though they work in the system, they were trained here. All of them spoke English as a first language, right? They still had a lot of negative experiences. And they were saying, well, how hard is it for all the families who don't have all the privileges that I have? I'll read you a quote from one nurse who said, I often say to myself, thank God I'm a nurse and I know how to navigate the system. On the other hand, It's not all perks. There were also some challenges to to being in this position. So, for example, SPs talked about the fact that they don't, um, all their colleagues knew their professional business. There were times when perhaps they were not happy with the care that their children were receiving from their colleagues, but they felt that their ability to advocate was limited because they didn't want to rock the boat either with the colleagues or with the bosses because they have to work with these people. And lastly, SPs talked about feeling isolated. And this was especially true for people from sort of smaller communities where it was impossible for them to build a network with other parents without, those parents knowing them in their professional roles. So here's a quote from one SP, and she said, "We went to an Easter Seals camp one time, and I hid after the kids went to bed because all the parents came out into the main area and complained about my colleagues, and I hid in the room." Uh, so it was really sad to listen to those stories of just feeling isolated and sort of feeling that they're not able to build the community because of that dual role that they're in. Okay, next slide, please. Service providers were really aware and really talked a lot about all the organizational and structural barriers to both receiving family-centered service as parents and then being able to provide it to their own families that they work with. So the barriers that they identified are all the typical ones, long wait lists, high caseloads, limits on, kind of how many minutes you have per patient, sort of strict and often arbitrary rules around eligibility for services and the number of visits per block of service. One healthcare provider noted that organizations operate on a business model, which she said is, and I agree, which she described as being fundamentally not compatible with family-centered service. And I will read you her quote. She said, "We are going to a family-centered practice, but we have these business managers back there who are saying, you have 15 minutes to do your documentation and you have this much time for a kid, and you are only allowed to see them so many times, like once a week and not more often. It is run like a business model, a lot of hospitals and centers, but yet they are saying you have to be family-centered." And lastly, another SP reflected that having a child with a disability opened her eyes to the fact that the medical system is ableist, as she described it, based on a medical rather than a social model of disability. Next slide, please. So on a related note, SPs talked about not being able to provide the care that they themselves would like to receive as parents. And there were a few exceptions to this. Some of the SPs who are in management positions talked about having, made some changes to service delivery. So, for example, mandating that their organization offers evening appointments, which nobody wanted to do. But then, since they were in a management position, they were able to make that happen. And one of the SPs had a teaching appointment, so she talked about sort of using her own experiences as examples of what to do and what not to do, but without necessarily sharing with her students that those were her own. But by and large, SPs felt constrained in their ability to provide the care that they wanted to provide and that they wanted to receive. So let me read a quote. "I cannot even provide the care that I want provided to me because of the way it is set up and because of the systems. When a family does give me their complaints, I say that I totally agree with them. Your hands are tied. With bookings, it is often central booking with someone who has no idea, and there are time constraints, and you are not allowed to use email or texts. There are so many constraints on you as a health professional. So at the same time, I am frustrated as a parent when it happens. I understand because as a healthcare professional, I am in the same situation." Next slide, please. So the majority of healthcare providers, as I said, felt that they were not in a position to influence or change the way that the delivery of healthcare services is set up in their organizations. And that was detrimental, obviously, to the families they work with, but also to them as parents and as professionals. A few of the SPs in the study shared that they had to kind of, step down in the professional roles. Some of them changed jobs, and two of them quit their jobs altogether because they weren't able to reconcile their work and their caregiving responsibilities. So I'll read you a quote from one SP who at the time was still was employed in the field, but since the interview, she also had she's still working, but she completely changed fields. So this is what she said. She said, "My son has a lot of events at school that I have to respond to, and that impacted my career very negatively if I had to step out and be a parent, even though I work in this field that helps children like my kid. It has a lot of stigma being a parent of a special needs kid, even though I work in the building where my son is a patient." Okay, and next slide, please. Okay, so that brings us to a close. I guess if I have to wrap it up or sum it up, somehow the big takeaways for me were that SPs who have lived experience, and again, we're focusing on the context of child health, but that can apply to lived experience in any context, have unique insights that can contribute to improving patient care. However, for the most part, the value of this lived experience is generally not recognized and not utilized by the organizations where they work. Although there might be some positive changes, but it's definitely not happening yet across the board. Okay, and next slide. I think that's our last slide, actually. So I just put a QR code if anybody is interested in learning more about our work, and our email addresses if you would like to connect with us. And now I think is a good time for me to stop talking and see if we can have a conversation.
Thanks so much, Kinga and Ray, for your presentation today. I know we have a few questions in the chat, so we can jump straight into that. I'm wondering, Fakria, did you want to expand a little bit about the question you were asking in the chat?
Yes, I was going to say that, as a parent of two kids with learning disabilities, I know that